Hello everyone, myself Dr. Mukul Sani. I am from Department of Respiratory Medicine. Today I am going to present pharmacotherapy of smoking cessation. So before starting the topic, let's look at some statistics. So among current cigarette smokers, approximately 70% would like to quit and about half try to quit each year. So spontaneous quit rates without any support is 1%. Simple physician advice to quit, then the cessation rates increase to 3%. So minimal intervention programs, counseling programs, the quit rate increased to 5 to 10%. So more intensive treatments including smoking cessation clinics can yield quit rates up to 25 to 30%. So before starting the pharmacotherapy, let's look at the mechanisms of addiction. What are the neurobiological mechanisms of addiction? Nicotine is absorbed rapidly from tobacco smoke or e-cigarette vapors into the pulmonary circulation. It then moves quickly to the brain where it acts on nicotinic cholinergic receptors to produce its gratifying effects within 10 to 15 seconds after a puff. Now, chronic exposure to high level of nicotine will cause an increased concentration of nicotine receptors in different regions of the brain. So, accounting for the development of tolerance and intense withdrawal symptoms, nicotine has half-life of approximately 2 hours. So, what do you mean by this? So, basically what happens is when nicotine receptor ka concentration will increase, so we will need more, body will need more nicotine for its to achieve that amount of gratifying effects which it was getting before. For example, by one cigarette, now the person needs 2 cigarettes to achieve same amount of gratifying effects. So this is because the number of nicotine receptors will increase, so more nicotine will be needed. So if that amount of nicotine patient will not get, then patient will develop withdrawal symptoms. So half-life is only 2 hours, so patient will get an intense craving for a cigarette or a e-cigarette or a tobacco smoke for the nicotine and its gratifying effects. So through scans also, suppose that if you take an example of a temporal cortex, if the CT scans are compared, the number of nicotine receptors in a non-smoker and smokers will increase in the cortical layers. So the cortical layers width will increase throughout multiple cortical layers because of the increased nicotinic receptors with time. So when nicotine is available, even is unavailable, even for a few hours, withdrawal symptom begins including anxiety, hunger, irritability, difficult concentrating, then restlessness, craving for tobacco, disturbed sleep, and in some people even depression. So nicotine basically binds to nicotine cholinergic receptors as we discussed before in various parts of the brain. Smoking causes upregulation of high affinity nicotinic receptors. So adolescent nicotine receptors also appears to alter GABA signaling in the brain, developing brain. So apart from nicotine receptor, there is some role of GABA receptors that too in children, not in adults. So GABA receptors are known to alter the nicotine reward system in adolescent age. So nicotine receptors activating facilitates the release of neurotransmitters including acetylcholine, norepinephrine, dopamine, which will give a reward sensation to the patient. So to achieve that gratifying effects. So nicotine receptor activation facilitates the release of neurotransmitters including acetylcholine, norepinephrine, dopamine, beta endorphin, GABA and others. So nicotine is basically a stimulant. So behavioral rewards from nicotine and nicotine addiction appears to be linked largely to dopamine release with impact on GABA receptors as well. So let's come to the strategies how we were able to make the patient leave smoking. So what are the main strategies for cessation? Number one, behavioral counseling, then pharmacological intervention, then the combination of the two, which is strongly recommended. Today we are going to discuss the pharmacological interventions. So this pharmacological intervention, so pharmacotherapy is divided into two lines of treatment. So first line and second line. First line, which is highly acceptable, which includes NRT, nicotine replacement therapy, then bupropion and varenicline. This is first line. Then comes the second line, which have little side effects, but then has to be used if first line is not working. So second line will include clonidine and nortriptyline. Let's come to first line, which is nicotine replacement therapy. So NRT is basically typically started on the person's designated quit date and includes nicotine gum, transdermal patch, nasal spray, inhaler and nicotine lozenges. So as soon as the patient decides to quit, you start NRT on the very same day. So it is available in various formulations: gum, transdermal patch, nasal spray, inhaler and nicotine lozenges. Patch, gum and lozenges formulations are available over the counter, which is available outside in every shop. And the nicotine spray and oral inhaler are available through prescription. So all have comparable efficacy when it comes to monotherapy. So although smoking cessation medications are recommended by the manufacturer for relatively short term use, like 3 to 6 months, but their use for 6 months or longer is also safe. So in pregnancy, recommended interventions are counseling and nicotine replacement therapy. So even if this patient is pregnant, you can still go for nicotine replacement therapy along with counseling, so which is very safe. Then comes to bupropion. So bupropion sustained release is a dopamine norepinephrine reuptake inhibitor, originally marketed and still used as an antidepressant. So what is the advantage of this bupropion over other drugs? So basically it is an antidepressant, yes. So suppose a patient is suffering from nicotine withdrawal symptoms. So if we give bupropion, it will help in the smoking cessation, and it will also help the depression which is occurring because of withdrawal of the nicotine. So it's good in both ways. So it has been demonstrated that the combination of bupropion with the nicotine patch is safe, and that bupropion alone or in combination was effective or more effective than the patch alone. So given its antidepressant properties, bupropion is a logical choice for smokers with depression. So common side effects are dry mouth and insomnia. Then comes the another first line therapy, which is varenicline. So varenicline is a nicotine receptor partial agonist that selectively binds to alpha 4 beta 2 nicotine cholinergic receptors in the brain. So a partial agonist means the drug will activate the receptor but at a lower level of agonist activity, about 50% of the nicotine. Excuse me. And also blocks the effects of other agonists like nicotine. So it primarily helps and works to alleviate nicotine withdrawal symptoms. In case of relapse, if the person smokes, then effect of nicotine are likely to be blocked by varenicline. That is another advantage. So side effects of varenicline includes, because it is eliminated from the kidney, dose reduction is required in the patient who is suffering from severe renal disease. So nausea and vomiting, so it is important to take it with food and a full glass of water. Now let's come to the dosage of the first line medications. So first line we discussed nicotine gum, nicotine lozenges, inhaler, nasal spray and patch. So as far as gum is concerned, we have to ask the patient symptoms. So if the time at which the patient consumes the first cigarette of the day. So if it is more than 30 minutes after waking up, 2 mg of nicotine gum will be given. If it is less than 30 minutes first cigarette, then 4 mg. Up to 24 pieces per day is allowed. Same with lozenges, 2 mg, 4 mg and up to 20 pieces of lozenges are allowed. Nicotine inhaler, 6 to 16 cartridges per day. Then nicotine nasal spray, 1 dose is equal to 1 spray in each nostril. So 8 to 40 doses per day. So that is maximum 5 doses per hour is recommended and acceptable. So and then comes in nicotine patch, more than 10 cigarettes daily if the patient is having, then 21 mg for 4 weeks, then 14 mg for 2 weeks and then 7 mg for another 2 weeks. If patient consumes less than 10 cigarettes per day, then 14 mg and 7 mg. Let's come to second line medications, clonidine and nortriptyline. So these have to be used when first line is not working. Then second line includes clonidine and nortriptyline. So side effects include rebound hypertension, dry mouth, drowsiness, dizziness and sedation. So acceptable dose is 0.15 to 0.75 milligram per day for 3 to 10 weeks. It is only available through prescription. Nortriptyline, there is a risk of arrhythmias. Then sedation and dry mouth includes as a side effects. 75 to 100 mg per day for 3 months. It is also available through prescription. So combination therapy is most important. So combination medications for smoking cessation can be more effective than individual therapies, particularly when combining long-acting medications such as nicotine patch or bupropion with short-acting NRT used at the time of intense urges. So only bupropion and transdermal nicotine in combination has been approved by the FDA. Few studies have found that combination of bupropion and varenicline was more effective than varenicline alone in a specific subset of patients with high level of dependency. Other interventions include exercise. During trials of smoking cessation may reduce anxiety, tension and stress. Walking on regular basis is a reasonable initial step and in many cases improve self-esteem and investment in health. Mobile phone texting and app-based smoking cessation has been studied in multiple settings. Acupuncture and hypnotherapy are also available. These interventions are either incompletely studied or have poor methodological quality to render a solid recommendation. So, thank you.